My name is Caroline Lozer, and I'm with the Lewin Group. This is the first webinar in the 2017 Geriatric Competent Care webinar series. Today's session will include a 60-minute presenter-led discussion, followed by 30 minutes for a discussion among the presenters and participants. This session will be recorded, and a video replay, the slide presentation, as well as the Q&A will also be available at https://www.resourcesforintegratedcare.com. If you'd like a copy of the slides from today's webinar, a link was provided in the chat box on the left of your screen. This link was also provided to you yesterday via email from webinars@confratel.net. This webinar is presented in conjunction with Community Catalyst and the Lewin Group and supported through Medicare-Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. MMCO is developing technical assistance and actionable tools based on successful innovations in care models, such as this webinar series. To learn more about current efforts and resources, please visit our website or follow us on Twitter for more details. Our Twitter handle is @integrate_care. Before we get started, I'd like to remind you all that all microphones will be muted throughout the presentation, but there will be a question and answer opportunity at the end of the presentation. If you do have a question, please use the chat feature on the platform to submit a question at any time during today's event. At this time, I'd like to introduce our moderator. Nancy Wilson is Associate Professor of Geriatric Medicine at Baylor College of Medicine and is Associate of the DeBakey, Virginia Medical Center. Nancy?
Thank you, Caroline. Good morning and good afternoon, everyone, and welcome. As a social worker here in Houston, Texas, and member of Community Catalyst's Geriatric Competent Care Planning Committee, I am honored to introduce this webinar faculty. Community Catalyst is a national consumer health advocacy organization whose mission is to organize and sustain the consumer voices to ensure all individuals and communities can influence local, state, and national decisions that affect their health. In partnership with the Lewin Group and the American Geriatric Society, Community Catalyst has been hosting the Geriatric Competent Care Series for the past 3 years, and we're excited that all this material has been archived. Last year, the focus was on the diagnosis and treatment of dementia, and today's webinar is taking us deeper into how states, health plans, providers, and community-based organizations are implementing promising practices for care of those with dementia for enrollees in the financial alignment demonstrations, also known as the duals demonstrations. I think you'll find their content and tools are also relevant to decision makers and providers in other healthcare settings. It's my pleasure to introduce our panel of speakers who will share with you their experience and knowledge and also direct you to some very practical and valuable tools. First up will be Deborah Cherry. Deborah is a clinical psychologist and the Executive Vice President of Alzheimer's Greater Los Angeles. Dr. Cherry received her PhD from the University of Southern California and completed a postdoctoral fellowship in geriatric psychology at UCLA, where she serves on the clinical faculty. Dr. Cherry has participated in the creation of numerous award-winning programs for people with dementia and their families. She's had a particular passion and influence on developing programs to increase access to care by ethnically diverse families. You may have heard of some of these, such as El Portal, the Latino Dementia Care Network, and its replication in African American and Asian American communities. She's also been involved in national projects focused on healthcare quality improvement, such as the Kaiser Permanente Dementia Care Project. At the national level, Deborah has served on the American Society on Aging's Board of Directors and has been a colleague of mine on the John A. Hartford Foundation's Change Agents Dementia Caregiving Network. Following Deborah will be a partner there in California, Linda Wade. Linda Wade is Director of Care Management at HealthNet, where she has worked for over a decade. In her current position in this health plan, Ms. Wade is responsible for planning and administration of case management services for all lines of business, including Medicare, commercial, Medi-Cal. She ensures compliance with regulatory, contractual, and accreditation requirements. Ms. Wade has both a business background, including an MBA from Pepperdine University, and a clinical background as a licensed registered nurse, and holds a degree in nursing from Azusa Pacific University. Using these skills, Linda has acquired over 20 years of experience in healthcare management. Her leadership experiences have spanned the continuum of care, including inpatient, subacute, and medical group settings. And we're particularly excited today that following Linda, we will hear from the most vital part of our workforce, a caregiver. Tracy Brown Lindsay is a caregiver living in Los Angeles, and where she plays a vital role in ensuring the quality of care and life for her mother. And we're grateful she's sharing her experiences and time today. The final speaker will be Tishla Curtis. Ms. Curtis leads the South Carolina Department of Health and Human Services Integrated and Coordinated Care Initiatives for the South Carolina's Financial Alignment Initiative, known as Healthy Connections Prime. She also has responsibility for the program of all-inclusive care for the elderly. Tishla began her work in South Carolina as a community relations hospice provider, where she assisted in the implementation of statewide outreach and marketing programs and assisted caregivers. She later joined the South Carolina Department of Health and Human Services under the Office of Long-Term Care and Behavioral Health. Currently, she works in the Office of Health Services as the program manager for initiatives that seek to improve care for Medicare and Medicaid enrollees. Tishla facilitates caregiver support groups and grief workshops and is a member of South Carolina's Coalition for the Care of the Seriously Ill, and along with Deborah, a member of the AARP Learning Collaborative on Family Caregivers and Managed Long-Term Care Services and Supports. She's a certified dementia specialist and is pursuing certification as a dementia dialogues trainer. So you've met our diverse faculty, and now we're eager to meet all of you. So we're going to do that through a process of polling. You're going to have the opportunity to respond to 3 poll questions, and they are going to be appearing shortly. We ask you to reflect and provide an answer quickly so we can see who's with us today. So polling question number 1, which of the following best describes your professional area? See lots of answers coming in, almost something in every box so far. So take about 5 more seconds if you can. And now, Christopher, if we could close the first poll. So it looks like we have a nice distribution of individuals with a number of different disciplinary backgrounds, with the largest percentage of people either being involved in the health plan management staff area or as social workers, but we have other medical care providers and some individuals in the other category. So we're excited to have everyone with us today. Polling question number 2. So you may have a certain disciplinary background, but may play another variety of roles with that background. So if you could just kind of identify yourself in that regard. Take a couple more seconds. And Christopher, if we can close this poll now. And again, it looks like we have a wonderful distribution, and I see voices of consumer advocacy showing up, as well as leadership at the administrative role, and also excited to see, Tracy, you have some family caregivers joining. So we're going to have all the stakeholders involved, and that's exciting for this topic. And our final poll question. So we're interested to know in what setting you work. We recognize that particularly within the financial alignment demonstration, there are a lot of different platforms of delivery as well as organization and leadership. So if you could choose which arena you're primarily working out of. Are you in home care, long-term care? Are you at the managed care organization level? And let's close this poll now, Christopher, and see where we are with results. And on my end, I'm not able to see our distribution, so perhaps because we have, there we are. Okay, so it looks like we have a number of individuals working at the managed care organization level, but we have all settings of delivery represented, which is particularly exciting, from the home, the community, long-term care. And we know that care for persons with dementia needs to be capable in a variety of settings, and a lot of that depends on systems leadership. So it's great to have all the voices here today. So at this time, we're going to hear from our first presenter. So I'd like to turn the webinar over to Deborah Cherry.
Let me thank all of you for being here today. I'll be speaking about California's MediConnect project and the dementia work we're doing within it. That's our state's financial alignment pilot. And let me note that California has 1.1 million duly eligible people, but our pilot operates only in 8 states. 8 of them, in 8 counties, 8 of the most populous counties in our state, with 11 participating health plans, each of which receives a capitated rate to serve members with Medicare and Medicaid, both through their medical providers and through their long-term care providers. These are usually Medicaid waiver providers, such as nursing homes and adult daycare. Since so much of quality dementia care is delivered in home and community-based long-term care settings, California viewed this pilot as an excellent opportunity to create systems of care with each of the health plans that could serve people with dementia in a more integrated manner and in their setting of choice, which is usually the home. Next slide, please. This project was supported through a number of funders. Let me particularly call out the Administration for Community Living's Alzheimer's Disease Supportive Services Program, which has supported the project through a grant to the state of California, and the John A. Hartford Foundation's Change Agents Dementia Caregiving Network for its remarkable support. Next slide, please. The Dementia MediConnect project had 5 components. We started with advocacy with health plans, and that advocacy was done in stakeholder meetings, advisory committee meetings, and with our state as they planned our duals demonstration. We made the case for focusing on dementia care within this capitated system of care. Then, with ACL support and foundation support, we were enabled to do care manager training and support, to provide caregiver education and respite, support services for families, people with the disease and their families, through referrals to local Alzheimer's organizations, and increasingly, we've provided technical assistance to the health plans to help them provide better dementia care. Next slide, please. So when we started with the advocacy, we had to make a case for improving dementia health care. And one of the first things we pointed out is that the numbers of people with dementia are growing. And while it's estimated that 10 to 11% of people age 65 and older have dementia, like an Alzheimer's disease or another dementia, the prevalence amongst the dual eligibles is much higher, perhaps as much as 23% of duals age 65 plus have dementia, largely, we believe, caused by their comorbidities that put them at greater risk. And these are expensive people to serve, which is what we pointed out both to our state and to health plans. And if you look at the chart, you'll see that they cost Medicare 3 times more than other beneficiaries. They cost Medicaid 19 times more than other Medicare beneficiaries. And that is driven primarily by nursing home utilization. Sadly, even though they're an expensive population, this group faces many barriers to obtaining quality care. You can see them on my slide. There is very poor detection of dementia. Therefore, people do not get appropriate treatment and management. There's poor recognition of the essential role played by family caregivers, and there is awkward connection to home and community-based services. The Dual Eligibles pilot provides us all with policy levers that can help us to move quality care forward. We looked in California at our three-way contracts between the states, CMS, and the health plans to find some of these levers. We also read all plan letters and tried to synchronize the goals of our project with the requirements in those directives. Next slide, please. So the project goal is creating a dementia-capable system or multiple systems of care because each health plan is different. And to do that, we had three goals. One, better detection and documentation of patients with dementia. Two, better partnerships with health systems and family, friend, unpaid caregivers. And three, better partnerships with community-based organizations. Let's review these goals and how we tackled them one by one. Next slide, please. We're going to start with the first goal, better detection and documentation of patients with dementia. And it has to be noted that only about 50% of people with Alzheimer's disease, a major type of dementia, ever get a diagnosis, and only about half of these have it documented in their medical records. So to achieve better detection and documentation of patients with dementia, members with dementia, we worked with the health plans to include a cognitive assessment question in their health risk assessments, to adopt a validated screening tool, to document the cognitive assessment in the medical record, and to establish a follow-up protocol for diagnosis if the cognitive screen was positive. And let me note that many times or several times health plans believed that they were doing a cognitive screen in their health risk assessments, but on further review it was revealed that they were screening for behavioral health issues, schizophrenia, and other issues, but not really for cognitive impairment. Next slide, please. So there are challenges to the recognition of dementia. As I mentioned, a lot of health risk assessments don't include screening questions for cognitive impairment. Families in the duals pilot may be less likely to bring dementia to the attention of a physician. They may have a lack of understanding of the condition, may think it's a normal part of aging. There's a lot of stigma attached to this condition. And many times the providers they see who are from their own communities may share cultural views about dementia and help families hide or deny the disease. So we need backup ways to identify these individuals. Next slide, please. One of the ways, as mentioned, was the review of health risk assessment content, and within a health plan or in partnership with a local Alzheimer's organization, you can do a review of a health risk assessment, make sure that there is some screening provided, a few questions that would then indicate the need for further screening. We, in our project, trained and provided technical assistance to care managers and others within health plans to encourage them to screen for dementia with a validated tool. This is not simply asking of a family member if their relative has Alzheimer's, but it is actually to use a validated tool. We particularly we adopted the AD8, which is an 8-item tool that can be used by telephone, either with the patient or with a family member. And then we developed with plans and provide technical assistance to some health plans to develop a follow-up protocol. These tools, each of the tools we'll be mentioning are available on our website, and we'll give you that link later. Next slide, please. So our next indicator of better quality dementia care was a partnership between health systems and family friend caregivers. Now, family caregivers are the backbone of our home and community-based long-term care system for people with dementia. Families fill in as the person declines, doing a wide array of tasks. And it is essential for health plans to recognize the important role that they play in caring for members who have dementia. So we work with the health plans to help them identify a family caregiver, document it in the chart, and assess that caregiver's needs. But that wasn't enough. They also needed to think about how to provide the caregiver with education and support. We had trained some dementia care specialists and had hoped that they would use plans that we had taught them to adopt so that they could provide more uniform care for these patients, these members, as well. Next slide, please. There were challenges to family-friend caregiver and are challenges to family-friend caregiver engagement. Medical providers may not have institutionalized systems that help them identify these individuals. They're trained to focus on the patient, not on the family or the caregiver. They may feel bound by HIPAA constraints not to engage with the family caregiver. But as a result of that, as the items on the slide show, they have poorer management of comorbid conditions, especially complex and multiple comorbid conditions, which we often see amongst the duals. There's apparent non-compliance. Physicians may not understand why the person isn't doing what they told them to do. There can be medication mismanagement, behavioral symptom mismanagement, and this all may result in unnecessary hospitalizations, ER visits, and maybe even in nursing home placement. Next slide, please. So for those of us working as care managers or healthcare providers, or for those of us who are advocates, working with health plans, we want to encourage that family-friend caregiver, or sometimes multiple caregivers, be documented in the electronic medical record or case management medical record, so that multiple providers see who is providing what services to the person with dementia. We provide on our website, which is listed on this slide, tools for identifying a caregiver, identifying their needs, and for assessing some of their stress and strain. We also encourage that specialized or trained care managers provide care to people with dementia and to their families, and that they use standardized care plans. Ours were derived from the Evidence-Based Access Program. Next slide, please. We also encourage health plans to link families to home and community-based services that are suitable for lower-income people. So most people with dementia do need some financial and legal planning, and you have to find no-cost or low-cost planning in order to meet their needs, because they can't afford elder care attorneys, for example. We also strongly encourage the delivery of education to family caregivers. And within the duals pilot, as you all know, the reading level for this training is supposed to be at 6th grade or lower. We have developed some plain language fact sheets for a variety of common behavioral issues that come up in dementia. Next slide, please. These fact sheets are available. This is an example of one in English and in Spanish, and later this year they will also be available in Chinese. Next slide, please. The third goal or indicator of our dementia-capable system was better partnerships with community-based organizations. Many providers believe it is enough to give a family a list of numbers to call, or even one number of a community-based organization. But frequently, families are so overwhelmed by care that they cannot take the step of making that phone call. So we encourage the adoption of a proactive referral tool that connects families to home and community-based services like respite care, support groups, caregiver education, care counseling. Our tool is called ALZ Direct Connect, and it does connect families to local Alzheimer's organizations. Next slide, please. This is what our tool looks like. It is downloadable from our website and can be adjusted for use in your local community with local resources on it. But the key is that you ask the provider, ask the family if it would be okay if a local Alzheimer's organization gives them a call. And then an organization such as mine, Alzheimer's Greater Los Angeles, would make the phone call to the family and see what their needs are, try to meet those needs or arrange for those needs, and give feedback to the provider. Next slide, please. There are challenges to having partnerships between community-based organizations and healthcare organizations. It often involves a culture change for both. Managed care organizations often expect you to be timely and provide feedback, and community-based organizations may not be HIPAA compliant. They may not have the capacity for large quantities of referrals. When we started getting referrals from our first health plan, it set our care counselors back with a waiting list of 2 weeks because we got everyone at once. So people have to consider where additional resources will come from to support the community-based organizations if they take on a large quantity of care for families from a managed care organization. And the partners need to invest some time in order to better understand each other's cultures, capacity, and services. Next slide. For the materials that we have developed, you can go to our website. Some of the things that we have on that website, which is on this slide, are sample health risk assessment questions and our training curricula, the ALS Direct form, a dementia care management toolkit that contains materials like a dementia screening tool and some caregiver identification and assessment tools, and a series of materials, tools that can be helpful to you in working with families to better manage some of the challenging behavioral symptoms that we see in dementia. Next slide, please. We also have a link on our website to 3 online training online training modules, which are available for a minimal charge, an hour on fundamentals of Alzheimer's for healthcare professionals, effective strategies for managing behavioral symptoms of dementia, that's a 2-hour module, and caring for the family caregiver. These are set up to provide continuing education units, I believe, for nurses and social workers, possibly for others as well. Next slide, please. So with our promising practice, what have we learned so far? And I have to say we are going into year 4 of what will be at least a 5-year intervention. Knowledge gain, which was measured in our care managers from baseline to a 6-month period, we saw that our trained care managers showed significant knowledge gain and that it was maintained through the 6-month follow-up. We measured system change by asking the care managers to self-report how they had changed, how they deliver care in surveys done at pre, post, and 6 months. And we also kept a system change spreadsheet, which was completed by project staff on the word that was obtained of health plan staff about improvements in care practices. Next slide, please. Based on the data collected from the care managers, we believe that the training did have an impact on care management practices. The purple line is baseline, and the 6-month follow-up with care managers appears in orange for each of these care practices. And they showed self-reported improvements in encouraging families to get a formal diagnosis, determining whether they have an informal caregiver, that's an unpaid caregiver, trying to improve the caregiver, involve the caregiver in the care planning process, referring the patient to home and community-based services, and their caregiver the same, and referring people to Alzheimer's organizations. All of these improvements were significant except for I usually involved the informal caregiver in the care planning process at the time of this data analysis that had not quite reached significance. But we are still delivering the training and collecting additional data, and we'll probably have final data in about a year to a year and a half. Next slide, please. Based on our system change spreadsheet, we've seen changes in HRAs in 3 health plans. 3 have adopted the AD8 in their e-record keeping systems. All say they're identifying family caregivers, and 2 have formally adopted a measure of caregiver stress and strain. 5 are offering respite, though we still question about how many families are actually getting respite. And 7 of the 8 we've worked with so far provide caregiver education and referrals to us. Final slide, I want to give recognition to my wonderful team. I want to encourage all of you, one more slide, next slide please. I want to encourage all of you to go to our website, alzgla.org/professionals, to get some of these tools. And now let me turn the presentation over to Linda Wade from HealthNet Health Plan.
Thank you, Deborah, and good morning, everyone. Next slide, please. As Deborah shared, HealthNet, along with other health plans, partnered with Alzheimer's Greater Los Angeles to provide tools to our case managers, members, and caregivers to better manage dementia and related diseases. Additionally, with the implementation of the MediConnect demonstration, we needed to develop an effective health risk assessment, and Alzheimer's Greater Los Angeles supported HealthNet in the development of that tool, and that was drafted including screening criteria for cognitive impairment that was recommended. Next slide, please. The key components of executing the plan for us, I'll review in more detail as outlined in this one slide below. First, we provided feedback to the Alzheimer's Greater Los Angeles organization in content development and class format for the initial 8-hour dementia training. They came and provided training to our case managers, which was a full day training for a large group of case managers, and then some of them were selected to go to additional training to become a dementia care specialist. When the team attended the full day training, so that was the whole team, they had the opportunity to go on a monthly or attend on a monthly basis clinical reviews with experts from UCLA, where we discussed our member concerns and questions, and they had the opportunity to learn strategies to help them better address the members' issues that they were dealing with at the time. We implemented the AD8 assessment and caregiver assessment, which I'll talk more about later. The training of our case management team on strategies for member management identified for care planning, such as combativeness, sleep issues, caregiver needs, and safety, was very helpful, and the training was provided in a manner where the case managers could practically apply the learnings into their conversations with the members, their caregivers, and integrate in a meaningful way to the plan of care. Next slide, please. As I said, Alzheimer's Greater Los Angeles provided the training of the HealthNet case managers, as well as our delegated provider groups who perform case management on the best practices for improving dementia care. HealthNet delegates case management to 17 provider groups for the MediConnect demonstration, and all of them participated in the training. Next slide, please. That training was during the summer of 2015. During that time, the groups were provided with an overview of the work and partnership with HealthNet. They reviewed best practices for dementia care, including tools that can be used by case managers, and they extended opportunities for the individual medical group pilots for further innovation. And as a result, several medical groups incorporated tools or adjusted their workflows within their electronic medical records to include or enhance screening tools and intervention. Next slide, please. The trained dementia care specialists who serve as internal resources for our care managers at the health plan and delegated provider groups are really important in supporting the ongoing recognition and learning for the team overall and being effective with the members. The training was, as I said, provided by Alzheimer's Greater Los Angeles. The dementia care specialists attended the monthly huddles for ongoing education and collaboration with other health plans and Alzheimer's Greater Los Angeles. And then they provided ongoing guidance and education to the care managers and members. Specialists also attend interdisciplinary care team meetings to provide consultations to the clinicians on specific member cases. Next slide, please. Most promising practices that we implemented were the AD8 assessment tool. That tool is used when a member does not have a diagnosis of a dementia-related illness yet presented with a thinking memory issue during their initial assessment or their health risk assessment. This was integrated into our medical management documentation system. If the AD8 yields a positive result, the care manager works with the primary care provider to make a follow-up appointment for evaluation for Alzheimer's or dementia-related diseases. The AD8 tool is incorporated as an indicator in our monthly internal health plan audit to assure our care manager utilization and understanding of the tool. And the caregiver assessment is integrated into our case management process. HealthNet recently joined the Centene Corporation, who owns many health plans across the United States. And as we have moved to our new case management documentation system, the AD8 and caregiver assessments were templated into the system for the case management team. And the value of the caregiver assessment was recognized and is available to the care managers, case managers at the plans across the United States. Next slide, please. Other promising practices are listed below. We partnered with the Alzheimer's Greater Los Angeles Community Education Department to develop a co-branded flyer for members in the community. We partnered to provide community education classes. We promoted the Alzheimer's Greater Los Angeles 24-hour helpline on the MediConnect member newsletter. And between 2014 and 2015, the HealthNet Health Education Information Line promoted the Alzheimer's Greater Los Angeles helpline upon member requests and inquiries. Next slide. I wanted to do a brief case study that walks us through the different steps that have been integrated from our learnings with the Alzheimer's Greater Los Angeles trainings. So initially we have a new member, and we complete their health risk assessment, and we identify a potential cognitive function deficit. The AD8 is completed with the member's grandson, who verified that the member has been positively diagnosed with dementia, but is being treated solely by his primary care physician. The case manager contacted the primary care physician's office to discuss a neurologist consult, and the member's grandson contacted to schedule an appointment as well, and the neurologist referral would be discussed at that appointment. This member receives in-home support services, but it's insufficient to meet the 24-hour care needs, and the member and the grandson report issues with frequent caregiver turnover and caregiver burnout. Next slide, please. The actions that the case manager took were to refer the member to a licensed clinical social worker to evaluate psychosocial needs. We also had one of the dementia care specialists review the case, and they provided the following recommendations. During the next follow-up with the grandson, complete the caregiver assessment to identify issues based on a report of caregiver burnout and frequent caregiver turnover. Provide education on the regional Alzheimer's Greater Los Angeles resources, and utilize the Dementia Care Toolkit resources to provide education on any behavioral issues identified during the assessment and incorporate into the care plan. Next slide, please. The challenges that we experienced during and after the implementation were, number one, data access and collection issues to evaluate the effectiveness of the program. And second is access to ongoing education for our new team members. It's such a great program. I really wanted it available to all of the team members, not those who were solely delivering their case management services to the MediConnect Duals demonstration members. Alzheimer's Greater Los Angeles responded to this need as evidenced in the resources that Deborah Cherry already has shared with you. Next slide, please. The outcomes that we have achieved are early identification and notification to the physician of a member's dementia-related symptoms for further diagnostic testing, continued support and education for care managers, increased caregiver knowledge and skill to better manage members, the ability to help prevent, reduce, or delay members' need to be institutionalized, to ensure effective member treatment plan is initiated for better member outcomes, the ability to provide appropriate resources for dementia-related care, data is reviewed to identify improvement opportunities, and the creation of a knowledgeable team of care managers to optimally respond to member needs. This has been the greatest gift to our team, as it has enabled them to reach their goal to positively impact our members. Now I'd like to turn the presentation over to Tracy Brown-Lindsay to talk about her personal caregiver experience.
Hi, hello, this is Tracy Brown-Lindsay, and thank you for having me, and I'm glad to be here today. I am the daughter and a full-time caregiver as well as an advocate for my mom, who's 89 years old. She was diagnosed with Alzheimer's disease in September of 2014. I made a choice to basically put my life on hold to be there as a caregiver for her. And I have found that it has been the toughest thing that I've ever had to deal with. But, you know, we're making it happen. After a couple years of noticing her cognitive decline, in my mom's memory, I decided she needed to be seen by a physician for an assessment. Not knowing what type of assessment or what the procedure was, I just basically depended on what the doctors recommended. My mom has been up and down, and you know, it's really hard to determine at the time that she started having these memory issues what was really going on. So at the time the doctor's appointment was made, she was given some screening tests that consisted of being able to remember certain things that were either shown to her or told to her. And with that, a diagnosis was made in less than 30 minutes. Well, I was a little blown away for that because I really wasn't expecting the type of test or the type of assessment that was done. But it was new to me, so all I had was to depend on the doctors, and what they determined was what was going on with my mom at that time. At the end of the assessment, my mom was prescribed some medication, which was called Namenda. It basically was told to me that it would help slow down the process. It wouldn't stop it, but it would help slow down the process, and that's all I was given at the time. Very few questions were answered. I didn't know what to ask, so I felt like maybe the doctors or the representative for the doctor should have at that point sat me down and described exactly what this medication was going to do, what the long-term condition would lead to, exactly what I'm dealing with. At the time, in my mind, I thought maybe a brain scan should have been done just to clarify the fact that she was diagnosed with Alzheimer's dementia. But to date, we've never had a brain scan, and it took a lot of phone calls, a lot of time, effort to even get to the point where we are now. I find it difficult to cope with her diagnosis at times. I don't get very much support from her health care. It's just frustrating. So I have now become her advocate, as well as being put on her advance directives and making sure that things happen for her. But I still find it difficult because her health plan still feels the need to make decisions with her, and she's not in a situation where she can make sound decisions, and I find I spend a lot of time going back and forth with her health plan on establishing my identity and what can and cannot be said as far as when I represent her, as far as a phone call or even a letter. It took a while, but eventually her healthcare organization, social worker, referred us to the Alzheimer's Greater Los Angeles. And I tell you, it has been such a relief to have phone counseling, education, chat sessions, and just overall support about her disease. My mom's current situation and her symptoms have started to change, so it's always good to know I have someone I can call other than her physician or her health plan that can introduce me to new things, new education, things that will help me. I have also been and have attended a support group where I'm able to talk to other people and caregivers that are going through the same thing as me. I have learned a lot and feel more at ease when it comes to my mom and her condition. My current situation was very stressful. My mom had a fall in December. She fractured her hip. She needed surgery ASAP, and it was very frustrating because the whole situation was just, nothing was explained, nothing was, every step of the way, I was there, but they still continued to try to talk to my mom. They had my mom sign her own surgery paperwork. They just basically acted as if I was not even there or I had nothing to do with her decision making. So it's just gotten to a point that, I really need more support from her health care plan, and I would like to stay more involved with the decisions, and I shouldn't have to explain every single time what my position is. I just find it frustrating, but again, now that I have more support on the other end, it makes it a little easier to deal with. In closing, I think it's very important to be connected with support groups and resources from the very beginning of the diagnosis. And as an advocate, you must ask a lot of questions and stay on top of your loved one's condition and at the different phases of the disease so you will be able to handle as the disease progresses. Give yourself a break as well and hire someone to come in part-time just so that you can stay right in your mind and don't get overwhelmed. Thank you for your time and listening to my story. Now we're introducing Tishla Curtis. Thank you.
Thank you, Tracy. I really appreciate all that you've shared about your support of your mother, and I'm very grateful for this opportunity to share from the South Carolina perspective. And next slide, please. What I hope to do today is just to give you a brief background and history of South Carolina and our experience in managed care, and then to talk a little bit about how that history and background really has informed our training approach and other requirements of our Medicare-Medicaid plans. And then lastly, we will just kind of give an overview of some of the early experience and accomplishments of our health plans and also the lessons learned from the state perspective. Next slide, please. South Carolina has operated our home and community-based programs for over 30 years, and so we have a very rich history and experience in that realm. This population primarily serves the elderly and disabled, but our history in terms of managed care has been much shorter, with mandatory managed care only being implemented in 2014, and then in 2010, and then in 2014 the state shifted to a full risk model in 2014. And even under that model, some populations remained excluded, including dual eligibles, individuals who are institutionalized or in one of our waiver programs. And so when designing the demonstration model and requirements, thoughtful consideration was really given to kind of our history and our background as we consider oversight of this population, and then also our maturation into managed care. Next slide, please. While our three-way contract does outline some requirements for health plans in terms of training, it was really our readiness tool that allowed us to assess the overall plan readiness to support older adults and individuals with dementia. The readiness tool, kind of as we modeled it and worked with CMS, really focused on the unique needs of individuals receiving long-term services and supports and delivery models that support older adults. The outcome of the review was really used to help inform ongoing monitoring and training efforts during the implementation. During the readiness review process, we did identify some deficiencies among our health plans, and those were related to just simply understanding South Carolina's delivery system in terms of long-term services and supports, reporting of critical incidents, and addressing health, safety, and welfare of enrollees through the individualized care plan. Next slide, please. And so again, kind of using that information to really inform the next steps, our state, we leveraged our existing partnerships with advocacy groups, academic institutions, and other state agencies to develop a series of trainings to help support our health plans. We worked with the Alzheimer's Association to customize advanced dementia training. And again, this training really aligned with some of the areas of concern that were identified through the readiness review. We've listed some of the topics that were covered, and we were very pleased with that partnership with the Alzheimer's Association. This training went for about 6 weeks. It was one day training each week, but really working together in partnership with the Alzheimer's Association to develop training that was really specific to the needs of the health plans was very important. Moving forward, we also have a contract with the University of South Carolina Office for the Study of Aging to facilitate training, including Dementia Dialogues. And Dementia Dialogues is a 5-session training course designed to educate individuals who care for persons with Alzheimer's disease or related dementias. And this is for individuals who are both professionals and are caregivers. This is a program that the state has been supporting for many years, and it's offered free of charge. The focus of the sessions includes an introduction to dementia, communication skills, safety activities of daily living, quality of life, addressing challenging behavior, and creative problem solving. This model, the reason why we chose this model was because it also includes a train the trainer module in which the health plans could integrate that into their kind of overall training for their staff. In addition to the dementia training, we also had training related to elder abuse identification and reporting. And this was really to help the health plans to understand their role in the investigative process and to also understand the role of South Carolina Adult Protective Services. And then lastly, we also provided training related to end-of-life care, and we really looked at the entire continuum from advanced care planning to palliative care to hospice, and how the health plans could help support both their members and caregivers through this process, with an emphasis really on the advanced care planning approach to really help support individuals who still were able to make those types of decisions early on, especially those with a mild cognitive impairment. Next slide, please. As we moved forward in terms of our training, we realized that we needed kind of a more accessible platform for training and all other educational resources for our health plans. And so in 2016, we moved to a e-learning management system, and this really helped us to reduce our training costs. It also provided a centralized platform for learning that included assessment and testing. And so now our health plans have access to this kind of on demand. And so even as they have new care coordinators come on board, they still have access to this information and training modules. Next slide. In 2016, we also introduced a repository of materials on our website. Again, this is really to enable health plans to have access to this information as their staff continues to grow as the demonstration progresses. Next slide. In addition to the training requirements, our overall program design also includes other features we believe are very essential to supporting older adults. We have a unified or uniform assessment tool that all of our health plans are required to use, and this was developed by the state. As a component of that tool, each of the plans are required to utilize the St. Louis University Mental Status Examination to identify cognitive impairment, and we chose this as opposed to the mini mental state examination because of the SLUM's ability to identify that mild cognitive impairment, which potentially is a biomarker for Alzheimer's disease and may occur in people as they progress from normal aging to Alzheimer's. And again, this was simply used as a screening tool, and it's not a substitute for diagnoses, but it helps the health plans to have a better understanding of their members. The tool is also used up front in the assessment process, and so if there's an identification of any sort of impairment, that would then kind of inform the care coordinator as to whether or not they should progress with the assessment or involve the caregiver. And another component of our program design was kind of the testing of a palliative care benefit, and this is a new benefit that's just restricted to the demonstration population. This benefit focuses on pain management and comfort care with the idea of optimizing quality of life for individuals with a serious chronic or life-limiting illness, including Alzheimer's and or dementia. And again, this is a recognition of the financial efficiency of using and leveraging palliative care for individuals with dementia. As we look at the costs of those of end-of-life services for individuals with dementia, it's almost doubled compared to those individuals without dementia. And then as a part of our quality monitoring, we also recognize that about 30% of elderly patient hospital admissions are linked to some type of drug-related problem or toxic effect. And so we've included an NCQA quality measure to monitor drug-disease interactions among the elderly. And lastly, again, as another requirement, in addition to the required reporting outlined in our three-way contract, the state also saw a need to clarify guidance in the role and responsibility of the health plans in not only reporting, but also investigating serious reportable events or critical incidents. And so this guidance really kind of specifies the role of the health plan through the investigation process, as well as documenting a detailed resolution. And for us, we identified kind of these critical events as falls, pressure ulcers, restraints, including both chemical and physical, elopements, suspected abuse, neglect, and exploitation. Next slide, please. We have just completed our first demonstration year at the end of 2016, and so we're still kind of early in our reflection process, but we have asked our health plans to identify accomplishments, promising practices, and challenges that they've encountered with respect to caring for individuals with dementia. And some of those things that, again, this is feedback directly from the health plans. They all have staff that have been trained in dementia dialogue. Many of the plans have integrated dementia training into their new employee orientation. They're sponsoring kind of dementia dialogue community sessions, and they've really expanded their resources in terms of care, their focus on caregivers. Health plans have developed toolkits. There's a greater emphasis on respite. We also have one of our health plans that's going to be conducting fall prevention workshops this winter. And so again, we've just seen how kind of creating an atmosphere, an environment where the health plans can really leverage their own innovation to take some of the tools that the state has given them, and then to go on to really expand those into other resources. Promising practices that have been identified by the health plans include just leveraging the state's dementia dialogue program at the health plan level, and then also educating and supporting caregivers. As an additional requirement, that the state also requires that each of the health plans have a quality improvement project related to caregivers. And so I think that too has really helped them to see the need to educate and support those individuals who are helping to care for their members. Some challenges that they've experienced, access to care. There are some barriers to institutional respite in South Carolina, and then also some limitations on our community mental health centers in terms of being able to support individuals with dementia. Some of the health plans have also experienced challenges with working with family members who may also have dementia, and so just again trying to navigate through that situation. Next slide, please. From the state perspective, there have been a number of areas of continuous improvement as well as positive experience or promising practices. I think the first one has been just optimizing existing state resources. Again, based on our kind of limited experience with managed care and with the elderly population being in managed care, it's really important for us to take a look at some of the existing resources in the state. And so we've been able to do that working through the Alzheimer's Association as well as with the university. And then in terms of interventions, I think that we still need to make some progress in making sure that there is meaningful care plan development that recognizes dementia or any type of cognitive impairment. And so as we move forward with the demonstration, that is something that the state will investigate a little bit more. And then also identifying caregivers. I think Deborah may have mentioned that during her presentation, but even as the health plans are completing their assessments, they're challenged with really being able to identify individuals who may not self-identify as caregivers in that assessment process. On the clinical side, there's still the issue of the underdiagnosis of dementia. When we take a look at the Medicare claims data for our population, there's only about a 6% rate of dementia diagnosis with that group. But when we look at the results of our assessments, we see a greater incidence of dementia among our members. And then with care coordination, some of the challenges is, for the health plans to figure out how to support individuals who refuse care coordination. And I think Tracy may have alluded to this during her presentation, just the, perhaps the frustration with, having a member who may still have some cognitive ability to make decisions for themselves and respecting those choices, even if that means that they refuse help. And so figuring out a way to navigate through that situation. We recently had one of our members who did refuse care coordination, and she was in the midst of a care transition from a hospital back home, ended up stealing her daughter's car and was missing for several hours. And so, again, the health plan has to figure out how to fully support a member during such a complex situation. One of the things that we have seen that's been very helpful is, again, using that the slums assessment early on in the assessment process to be able to identify a mild cognitive impairment that would, again, result in perhaps bringing in another individual to help complete the assessment depending on the results of the slums tool. And then lastly, what we hope to do moving forward is to really drill down a little bit more on the quality side and to focus on the use of seclusion across all care settings, not just in facilities. And that's going to take some innovation on the part of the state as well as our health plans. But in general, we've been very pleased just with our health plans' application of some of the tools that we've given them, and then how they've also been able to, in some respect, organically develop their own programs in-house and really leverage some of the work that they've done nationally and in other states. Next slide. And this slide just gives you links to various resources that we've talked about during the presentation, including our readiness review tools and some of the assessment tools that we use in our comprehensive assessment. So thank you again for the opportunity to share today.
All right, well, thank you so much to all of our speakers. Thank you, Deborah, Linda, Tishla, and Tracy for your presentations. This has been incredibly informative. Thanks so much for joining us today. We have a few minutes now for questions from the audience. And I also just want to make one announcement that the recording of this event, as well as the slides, will be available shortly at https://www.resourcesforintegratedcare.com. At this time, if you have any questions for our speakers, please submit them using the chat feature on the lower left of the presentation. Type your comment at the bottom of the chat box and press Enter to send it. And just to start off, Deborah, we have a few questions that we would like to ask you. Specifically, we had some questions about the standardized care plan. And we had one question about how the standardized care plan compares to a person-centered plan.
You know, the standardized care plans can feed into a person-centered plan, and indeed we hope that they would. What they do is they provide suggestions of where the care manager can go for additional resources, what the care manager may want to say to the physician or medical care provider, and also where the care manager might go for materials that they can share with that family. So that they can help with education of the family. So it is not to take the place of a personalized care plan. It is just recommendations on different issues like bathing or agitation or combativeness.
All right, thank you, Deborah. We have another question for you. So for the California project, it was based on increasing capacity for the care managers. So we have a question. They're interested in how many or what percent of duals are served by care managers. And is care management primarily provided by phone or in person too?
So, you know, I don't know if I can give you a precise number of people who are duals in the state who are getting care management. The state, much fewer people have signed up for MediConnect than are dual eligibles in the state of California. I could be corrected by Linda, but I believe that the sign-up number is something like about between 250,000 and 300,000. All of these people who are in MediConnect are supposed to have access to a care manager if that is what they desire. However, they are actually referred to a care manager when they have indicators that when they are graded in a higher need category. And that often happens because of their use of lots of long-term care services or hospitalizations, emergency rooms, and so forth. So we have low, moderate, and high-risk people gradations, and the high-risk people get to care managers pretty much automatically, whereas those at the lower levels have to request care management in order to get it. Did I miss any other part of that question?
No, that was great. Thank you, Deborah. And we do have a few more, so just one more for you. Can non-clinical staff administer the AD8?
Yes, I believe that non-clinical staff can be trained to administer the AD8. It's a fairly straightforward tool and very flexible. I believe the other question that someone asked is, how is most of this care management delivered? And our experience in California is that most of the care management in MediConnect has been delivered by telephone, but certainly not all of it. And there are situations where care managers can do home visits and go out to the community to see the family, person with the disease and the family member. But the great majority of care management, at least in the MediConnect project, is being done by telephone.
Thank you, Deborah. And Linda, we have a question for you. We were wondering if you could elaborate a bit further on the training of the dementia care specialists.
Certainly. So the care specialists, they had a particular toolkit that expanded on the initial one-day training. And Deborah, I need you to remind me if it was like 2 full days of training.
It was in addition to the 8 hours that was given to all care managers, the dementia care specialists got an additional 12 hours, a day and a half of training.
Thank you. And then the materials go through different tools for caregiver identification, care needs assessment, and care plans for challenging behaviors using a particular strategy they call IDEA strategy. I think Deborah talked about that a little earlier. And what was really nice about it is it just talks about, the problems that that people have to deal with: sleep disturbance, depression, hallucinations, sundown, suspiciousness, screaming and making noises, how to help someone on a daily basis with their bathing and showering, eating difficulties, toileting, safety, and then there was a section on the caregiver needs, talking about safe body mechanics, understanding of dementia, legal and financial planning, long-term care planning, and life planning. Did I answer the question?
Yes, thank you, Linda. So we're going to move over to Tracy. Tracy, we were wondering what kinds or types of support groups exist for family caregivers. What has been your experience with that?
Well, after doing a lot of searching on the internet, there's plenty of places that you can call, places that you can access chat groups. But I find Alzheimer's Greater Los Angeles has been the most instrumental in helping get me through some of the toughest times that I have, and most times it's just asking simple questions that can help me, get to the next level.
Thank you, Tracy.
Okay. Did that answer the question? I'm sorry.
No, I think that absolutely did. And if anyone has any follow-up questions, feel free to type that in the chat and we can read that out loud.
Okay, great.
Thank you.
Thank you.
All right. And Tishla, we have some questions for you as well. How has the state worked to ensure health plans support the types of resources you find families need the most?
We've really given the health plans kind of just simple parameters in terms of how they support families and caregivers. I think for states, we have to balance being very prescriptive and also giving health plans an opportunity to really innovate. And so, again, a lot of the development, especially on the caregiver support side from the health plans, has really been organic. It has not been anything that's been prescribed or dictated from the state. And at least from South Carolina's perspective, we believe that that is the right approach right now, given where the state is with its development of programs to help support individuals with dementia and older adults in a managed care environment. And so that's one of the things that we've done. But we've also helped to connect our health plans to other community-based organizations where, including the Alzheimer's Association, all of our AAAs, et cetera, so that they are aware of those resources and can leverage them into their own program model.
Great, thanks for sharing, Tishla. We did have another question come in for you. So in South Carolina, are the care managers interacting via phone or in person with the health plan members?
The comprehensive assessment for South Carolina is required to be face-to-face. There are some components that can be conducted telephonically, but for instance, the slums is part of the assessment that has to be done face-to-face. And then on an ongoing basis, we also have a timeline for interactions with members based on their risk stratification. High-risk members, and those would include individuals who are receiving long-term services and supports, have to have interactions, face-to-face interactions on a monthly basis. And then kind of moderate to low-risk individuals every 90 days. And so we really stress the face-to-face component to not only be able to connect with the members, but also to be able to do an environmental scan of the home. As a part of our assessment process, each of the health plans has to conduct a home assessment for their members, and that can address any kind of issues that put members at risk for falls, et cetera. And so that again was our approach with the program design.
That's great. Thank you, Tishla. I'm going to move back up to Tracy. We did have a follow-up question for you. So Tracy, what was the most helpful resource you obtained, and how did you get it? For example, support group versus a telephonic support.
Okay, as I indicated, Alzheimer's Greater Los Angeles has been the most instrumental out of all the referrals or resources that I have been told about and given. And I've had both one-on-one phone conversations as well as group sessions that both of them are equally important to me. And, you know, it's just the more information I have, the better for me. It helps get me through it. It's just searching, and there's always new information. I keep in close contact with Alzheimer's Greater Los Angeles because there's always something new. And I don't get that much support from my mom's health plan at all, period.
Thank you for sharing, Tracy.
Okay, thank you. You're welcome.
All right, and Deborah, there are a few more questions for you in the queue. So we have one question. What tools or tips do you recommend for healthcare providers to be aware of community-based dementia services?
You know, I think it's pretty easy to find out who is providing dementia care in your area. You can basically go online and put in the word Alzheimer's and put in your area. There are community-based Alzheimer's organizations all across the country. And then I would say that it would be a good idea to try to have a meeting if you're from a geriatric clinic or you have a number of families with this disease, have a meeting with one or two of your local providers and decide who will or whether they both will provide a range of good services for that family. Then, I recommend people use that ALS Direct Connect form I mentioned earlier and individualize it for your local community, getting the family's permission to have the local Alzheimer's organization contact them proactively. And that will help the provider know that they have connected the family with complementary services like the support groups and disease education. And it also they can express their desire for the community-based organization to provide them with feedback from that family. And as a community-based provider, we get permission from the family to provide that feedback, just like medical providers get permission from the family for us to call them. And it seems to work well.
Thank you, Deborah. We have another question for you. Do any of the plans or programs you work with allow caregivers to view any of the care plans or medical care plans or health records?
Well, the answer is yes. So some of the health plans are experimenting with having a family member or a paid caregiver on the care team. They have what are called interdisciplinary care teams that develop these care plans, and it varies from plan to plan, but some of them have been taking steps to engage the family in the care plan development and do share the care plan with the family member. It's a promising practice. It is not widespread.
Sure. Thank you. And Tracy, we're going to jump back to you. We have two more questions in the chat for you. The first one, what are the expectations from the insurance company as far as information they should provide to you?
One of the things, like I said, when my mom was first diagnosed, we left there with a couple of pieces of paper that had a lot of contact information. I'm a hands-on type of person. I would have gladly welcomed someone actually sitting down saying, this is where you need to go. These are different resources, but this is what you need to look for, because when you're newly diagnosed, you're blown away. You really don't know what's going to be good for you or what type of questions to ask. So I would have appreciated her health plan to be a little bit more compassionate and, try to guide me through the question process and, helping me decide what I need to ask because you really don't know.
Sure, absolutely. Our second question for you, Tracy, what was most surprising information you have learned about caring for Alzheimer's patients?
As my mom's condition progresses, I'm finding it a little bit more difficult now, but I'm not going to say it's difficult in getting answers because obviously we have the internet that we can always lean on, but a lot of this information that's on the internet is not as I just don't find a lot of it credible. I like to deal with people that are actually going through it. So getting, like with Alzheimer's Greater Los Angeles, you can be put in touch with others versus just, guessing, okay, when you pull up a Google search, you say, okay, I'm going to choose this one. Is this the right person or is this the right group that I really want to be connected with? So it's just getting information. I mean, and you have to know where to look. And I think being with an association like Alzheimer's Greater Los Angeles, it helps me. I can't stress enough how their association has helped me through this whole process versus the health plan, which, I could probably, if I push a few buttons with her health plan, which I usually do, but the whole thing is getting return phone calls, you leave messages, you're transferred to this person transfers you to this person, so you get so frustrated, so you go back to where you can get answers. And, I can't stress enough how important it is to have a live person to talk to versus being told, here, go to this website, and, so on and so on.
Yeah, absolutely. Thank you for sharing, Tracy.
Oh,
with that, we just have a few minutes left, so I'm just going to close with some final remarks. So any questions we did not have time to address will be posted to our website in the form of Q&A, so look out for that. If you have any additional questions or comments, please feel free to email us at ric@lewin, which is lewin.com. The slides for today's presentation, a recording, and a transcript will be available on the Resources for Integrated Care website shortly. Thanks again to all of our speakers. Have a wonderful afternoon, and thank you so much for your participation.